So this next section is still on burns, talking a little bit about skin grafts, skin debridement, and wound care itself. Some of the student learning outcomes for this skills lab are repetitive from the theory, and so you may see a few of the slides that are familiar to you already. We will be utilizing case studies, also reviewing findings, and then just discussing some of the highlights on this PowerPoint. Thermal burns can be minor, serious, major, or life-threatening. So how do we classify those? Again, looking at a minor burn, those would be something that a patient would just need to seek medical attention, possibly at a doctor's office, or just take care of at home. Something that is more serious or major does need to be seen in the emergency room for proper assessment. And then life-threatening, we would have problems that may have caused some inhalation problems and inhalation burns, and or burns that maybe are total circumference of a total extremity, and or maybe the chest has been burned and now we have problems that could arise with respiratory issues. Severity is determined by the depth of the burn, the extent of the injury. Also looking at the total body surface area, or the percentage of injury in relation to the overall body surface area. Location of the injury, of course, age of the burn victim, because we know that the very young and the very old are more feeble and brittle and don't tolerate things like this as well. And then whether or not there are any other injuries sustained during the burn, and then we need to always consider our past medical history. When a thermal injury occurs due to prolonged hospitalization, we need to make sure that we are doing comprehensive nursing and that we are looking at both acute and long-term recovery phases. We need to have a basic understanding of the complexity of the care that is required. And again, like we talked earlier, how somebody with an inhalation burn can have problems with their airway. We need to make sure that we are monitoring that and providing good respiratory care for that patient. Also understanding the client's response to the injury. So looking at the individual patient and focusing on how we can help that patient best. Nursing care for wound management in the resuscitative phase. Again, we need to look at life and death. We have to secure the patient's airway, number one, supporting adequate breathing and circulation, whether it is through the use of breathing treatments and or giving oxygen and ventilation. And then also we need to be looking at limiting the extent of the injury, so caring for the wounds so that we can have the best outcome for that patient. And then lastly, maintaining functions of the vital organs, because you see from our first presentation that the more surface area that is burned, the deeper that the burns are, we do have problems that can occur not only with the skin itself, but with the lungs and the kidneys and the heart and so forth. So now let's look at some specific management things that we need to do in the resuscitative phase for the different types of burns. And we're going to start with flame burns. And so one of the main things that we need to do is make sure that the flames are smothered out, whether we cover them with a blanket and stomp them out, or whether we utilize a fire extinguisher. We need to remove smoldering clothing from our patient, and we also need to make sure that all metal objects are removed from that patient so that we decrease the chance of burning the patient burning even worse. And looking at chemical burns, some of the management that we might need to consider would be if the chemicals are dry chemicals, we need to make sure that they are just brushed off. We don't want to wet the chemicals on the skin at all, because that will cause a worsening burn. Also, again, removing the clothing to get the chemicals off of the skin. We need to identify what type of chemical it is, and then potentially just call poison control for that. And then if the chemical is positively identified, neutralize it with the appropriate agent as per instructed. Now let's look at electrical burns. So main thing is at the scene, we need to make sure our patient is separated from the electrical current. Um, and then if there are any flames, we need to smother them out. This patient probably will be needing CPR, so we need to assess the patient, airway, breathing, and circulation, and immediately start our CPR if necessary. The other thing will be obtaining an EKG as it's available, because just like we talked about in the other PowerPoint, electrical burns can and do go in one part of the body and come out in a different part. So if it crosses the line of the heart, we can have problems with dysrhythmias. With radiation burns, the things that we need to do are remove the radiation source, and also removing the clothing that the patient might have on. We need to make sure that we are utilizing protective gear such as tongs or using lead protective gloves, and that will help avoid radiation contact with a caregiver. If the radiation gets on the skin, we need to make sure that our patient gets sent to a decontamination center for proper care, and then they will be needing to be assisted with the bathing or shower to get their skin free of the radiation. And lastly, the management for the thermal inhalation injuries. Again, that is a patient that has been maybe in a house fire, has burns to the skin, but also has inhaled smoke. We need to maintain their airway, and intubation should be expected with this patient. We want to make sure that we maintain that airway as soon as possible, because that swelling, like we talked about earlier, can occur fairly quickly, and we want to make sure that they are oxygenated well. And of course, managing pain is going to be another priority for our patients. So we need to do a good assessment not only before but after any procedure that we do on our patients. I think our PowerPoint this morning did mention some of the drug therapy that would be a possibility on these patients. So opioid analgesics might include morphine, hydromorphone, fentanyl. We may have non-opioid analgesics, and then also anesthetic agents such as ketamine and nitrous oxide may be used. Again, we talked about the importance of everything being given IV, because patients that have medications that are given injectable, such as IM or sub-Q, may have that delayed reaction, and we can have a lethal amount that is built up into the blood. Also, PCA is a great opportunity for the patient to be able to control their own pain, so that may be something that you might consider in discussing with the physicians. And then again, make sure that we are monitoring for respiratory problems with these patients because of the opioid, and also because of other respiratory potential complications, and then looking at things like problems with bowels. So always assessing before and after your procedure for pain, and then after the procedure you want to make sure that you've monitored those other particular things too. And some of the things considered surgical management: if our patients have been intubated and they have been intubated for quite some time, or if they have severe airway edema, our patients may need to have a tracheostomy placed, and then have the tracheostomy tube where we're supporting their ventilation with that. Also, we talked about chest tubes just a little bit, but for those patients that have had other injuries associated with the burns, such as maybe they fell and also ended up with burns, we need to be looking at our lung capacity. The other thing is we need to consider is that at any point, if we are not doing deep breathing because of our burns and the pain of our burns, we can have collapsed lungs that can occur spontaneously. So chest tubes may definitely be something that needs to be warranted for these patients. And then lastly, escharotomy, and with that, fasciotomy. And that would be if there was too much swelling around a circumference of a wound, and it was impeding the circulation to the skin tissue. They may have to do an escharotomy, which is just that top layer that they're cutting open, allowing for a little bit of expansion, and then a fasciotomy would actually go all the way through to the muscle. So with that, we would have to make sure that we did good infection control measures, wound care, and good wound assessments on these particular patients. And here are some great pictures of escharotomy. And again, you can see that a couple of these are on the upper extremity, so we worry about the constriction and the buildup of fluid on the hand itself and the tissue that can actually cause a decreased tissue perfusion. And then one of the pictures is a picture of the chest, so they're actually relieving some pressure so that patient might be able to do a little bit better deep breathing and maybe prevent some other complications such as our pneumothorax. So I know we talked about this already on the previous slide, but I think these are some great pictures for you to take a look at. Nursing care for the wound management in the acute phase is going to begin when the fluid resuscitation is finished and the fluid shifts has resolved. So this typically takes anywhere from 36 to 48 hours post-injury. We do want to enhance the wound healing, so we may need to be looking at debridement of tissue that is dead and does not have good circulation, also preventing complications, so good infection control measures, good hand washing, use of sterile supplies, and potentially even doing sterile dressing changes, for sure using surgical asepsis. And then also we need to realize that this phase is going to end when the wound is completely covered over by tissue. A nurse that works in a burn unit, even in just a main type of a hospital, becomes very important that they are coordinating with other disciplinaries. And so not only for them to make sure that they are maintaining good assessment skills and then the care that goes along with the wounds, but also bringing in other people such as a dietary for nutritional status and helping with the high protein, high calorie diet, looking at possible wound care nurses and special wound care doctors that may need to be seeing them on an outpatient basis. Also pain control, so we may need to pull in our pharmacy and or pain control specialists. And then also thinking about psychosocial interventions. So we might have to think about utilizing a chaplain or social worker, something that is going to help support them throughout this changing time in their life. So in wound debridement, the purpose of this is to prepare our wound for grafting and for closure by natural healing. And it is, again, the removal of the eschar or the other cellular debris that is on the wound itself. This can be done surgically, mechanically, or enzymatic. And then our priority nursing care include assessing the wound, providing good wound care. Again, we talked about utilizing infection control measures, preventing infection and monitoring for infection, and then preventing other complications that could occur due to the nature of the specific burn itself. Mechanical debridement is burns that are debrided usually 1 to 2 times a day, utilizing hydrotherapy or the application of water for treatment. Nurses can do this, skilled technicians can do this, and also physical therapists. Sometimes we do have to allow a unlicensed nursing personnel to place the patient in the therapy itself. However, I want to remind you that nurses always do the assessment of the therapy itself and also make sure you're monitoring that. So with the use of hydrotherapy, they do not recommend submersion in whirlpools or baths any longer due to the risk for infection. However, use of showers or special shower tables have been used, or you can wash small areas at the bedside, removing of loose dead tissue with forceps and scissors. Large blisters are opened, and smaller blisters are usually left intact as a barrier themselves. Use of washcloths or gauze sponges will help remove the soft, cheesy eschar and then you'll wash with mild soap and water at room temperature, and then making sure that they get rinsed well. With enzymatic debridement, the disintegration of tissue by action of the client's own cellular enzymes is known as autolysis. However, there's a very high risk for infection with this particular type of enzymatic debridement, and it's a slow process and also results in lengthy hospital stays. Another alternative to this enzymatic debridement is artificial application of exogenous agents such as collagenase, or sometimes you may have heard it called Santal. This is applied one time a day with a dressing change. What happens in this particular debridement is the enzymes digest collagen in the necrotic tissue, and it helps clean that wound up to allow for healthy tissue to start growing from bottom up. Dressing burn injuries are typically standard dressings utilizing cleansing with sterile saline or sterile water, application of topical antibiotics, utilizing multiple layers of gauze to keep it protected from bumping or injury, wrapping it with a roll such as a Curlex, or applying a circular net type dressing to keep the dressing intact without utilizing tape, and no putting tape on the skin. Sometimes they do put an elastic wrap on. This would help with return circulation. And then dressings many times are changed every 12 to 24 hours. So daily to BID, you might expect dressing changes. Due to high infection rates, again, dressing changes should be aseptic, and so use of sterile gloves and also sterile supplies are an absolute must. Continuing talking about dressing of the burns, there are several different types I've got listed here. Biologic dressings are temporary wound coverings and closures that are made of skin or membranes from human or animals that provide healing or prepare for permanent skin grafting. So the different categories that fall underneath that include homografts or autografts. That is from a human source. Just note those are very costly, and you have high risk for bloodborne transmissions with that. There's heterograph or xenograph, and that's another species. However, that happens to come from pig skin, known as porcine. There's cultured skin, which is grown from a small specimen of epithelial cells from unburned area. So that's where it's grown in a lab and then utilized at the correct time. And then artificial skin is a substance with two layers. There is a celastic epidermal and a porous dermis made from beef collagen and shark cartilage that is used. And then once that top layer starts dissolving, it is replaced with what they call a neodermis, and that is blood vessels and conductive tissues that help support healing. The next classification here is biosynthetic, and that's a combination of biosynthetic and synthetic materials that allows exudate to pass through the dressing itself. And then synthetic dressings are transparent, and they're made of solid silicone and plastic membranes that are applied directly to the surface of prepared wounds or wounds that have been cleaned and remain on until they've fallen off or until they've been removed. So this is just some different dressings that can help support burn healing. And this slide just has several different types of the dressings that you might expect to see. Also, those are found in your book. Surgical management or excision of burns is typically used for the treatment of full thickness and deep partial thickness wounds. It is performed within the first 5 days after an injury, and then again as needed. And what the provider does is they excise the burn tissue by removing the tissue of thin layers of skin off until there is a bleeding tissue layer found. That just means that they've gotten down to a healthy layer that can allow for skin healing. And also then grafting post the excision is typically what they need to do at that point. And then there's surgical management through the grafting. So they typically will do the excision first and then utilize the grafting for wound closure This is used for non-healing wounds, loss of joint function, unacceptable cosmetic appearances, or somebody with body image issues and severe deformities. High potential wounds recurrence is definitely a problem with this. It does require clean and granulation of freshly excised wound bed, so the procedure we just talked about prior. Removal of partial or full thickness strips of skin from the donor area is the process, and then it's transferred to the graft site as needed, and then suture or staple in place. This does reduce healing time, and risk for infection and sepsis is much less. Nursing care post-op grafting would include immobilization with bulky cotton pressure dressings for support and protection of that wound, allowing vascularization within 3 to 5 days. So 7 to 10 days posterior sites are needed as opposed to anterior sites. And then elevation and rest of the site. We also need to monitor for failure to vascularize, and so I want you to think about what that would look like. So if we have a patient that has just had a graft placed, what signs and symptoms would you be watching for on that graft site when you did dressing changes? So looking for color changes, you know, if the skin is white or pale or black, obviously those are signs of either impending tissue perfusion or tissue death. And then we also need to be watching for signs of infection, so redness, swelling, excessive drainage with a foul odor, temperature elevation. Those are all things that you would need to monitor your patients for post-op grafting. So we want to minimize infection, and two definitions here are auto-contamination and cross-contamination. Auto-contamination is where the patient has their own normal flora that overgrows and then invades the body areas. So that would be like our patient has wounds in several different sites, and we want to prevent moving growth of germs from one area to the other. So as a nurse, what we would need to do is utilize our good hand washing, but then also utilize wearing gloves from one wound area to another. We need to change our gloves in between going from one area to another. Cross-contamination would be our normal, infection that could happen from other people, other patients, other environments. And so what we try to do is just protect our patients the best we can. And that's why we do infection control measures. We gel in and gel out, do good hand washing prior to taking care of our patients, wear clean gloves, and utilizing good technique and clean supplies. So the other thing is infection control for patients that have large amount of body surface area burns. We may have to put them in isolation, and or if they are neutropenic in any way. Watching for signs of infection such as foul smelling discharge, also fever, and then watching our white blood count elevations. We want to make sure that our elevations are not going up and they are going down. Also, we may need to do blood cultures for colonization in the blood itself to make sure our patients are not septic, and if there is anything that's growing, that we are treating that properly. Also doing wound site colonization, so culture our wounds, and then waiting for response on which medication the particular germ is resistant to. Also, we talked about administration of tetanus toxoid on your homework assignment, and then the administration of tetanus immunoglobulin or hypertet if we don't know the patient's history. And also use of antibiotics becomes important. So some topical antibiotics, we know that they come in forms of ointments and creams, and usually they're applied 1 to 2 times a day with dressing changes. And then your book has a great table on page 501 that talks about many of the other products, such as Mepilex, which is one of the main ones that I have seen used at the hospitals but they are left on the wound for several days, typically up to 7 days, and it eliminates the need for dressing changes, but it helps with the wound healing itself. And then sometimes we do have to put our patients on systemic antibiotics. Again, those are going to be patients that have positive blood cultures and septicemia, or possibly positive wound cultures, and they need antibiotics for that. So broad spectrum antibiotics are typically given until our blood cultures and or our wound cultures are back and available. And then the other thing is avoiding foods. So our patients that have are immunocompromised, we want to make sure that they are eating foods that are not going to introduce any additional bacteria in them. So well-cooked foods, no fresh fruits and vegetables, probably to avoid until they get out of the woods. And last but not least, after we provide our care to our patients, we need to make sure that we are documenting things. Prior to discharge, we always want to make sure that we are documenting the wound appearance and the wound care that has been provided. And then on discharge, we want to make sure that we are reporting to the patient what signs and symptoms of infection to report, teach them about their medications and the proper way to do dressing changes, also proper use of prosthetic and positioning devices, such as the compression devices we talked about, and also sometimes we do have to have a patient that has some kind of a wrap on that. Comfort measures to produce itching, because we know that depending on what the temperature is, if we have a lot of dressings that are on, sometimes the body can get hot, sweaty, and have some itching. And also as the skin starts healing, you may see some itching. So comfort measures to provide that. Always keeping follow-up appointments so that we can be monitoring healing and pick up on any problems early. And then also utilizing any healthcare resources, potentially home health for continued dressing changes and or other resources. The rehabilitation phase does begin on admission. Technically, it starts with a wound closure and ends when the highest achievement level of functioning has occurred. A reminder that this can take years or even a lifetime, so patients need to be really educated well on how to care for their wounds and how to care for their skin to prevent other problems. So your book has a chart on page 503 that I want you to take a look at, and then also on 504. So positioning to prevent contractures is going to be important, utilizing range of motion to keep everything from stiffening up and having contractures form, making sure our patients are walking and ambulating to prevent other problems, use of compression dressings, and then supporting a positive self-image, because psychosocially is going to be really difficult depending on what areas are burned and if they are visible, like the arms. They may have trouble wearing short sleeves, or I have known a young girl that was burned in a fire and her face and her arms were distorted. So those are psychosocial and body image issues that we need to be thinking about and working on with those patients. And then again, the discharge needs become very particular with this type of a patient as opposed to other patients. So take a look at those charts on 503 and 504. Now I want to remind you that it is important for you to continue your study. I know that our platform has been changed just a little bit. However, you have all the information to be successful, and I just want you to remember that it's important for you to study, schedule specific study times throughout the day, every single day, so that at the end of this semester, you'll finish strong. So I just want to encourage you to watch the ball and swing for the fence. So knock it out of the park.